Hey Med-Surg dudes, how you doing? I am going to show you the Pleurovac closed drainage system. Now this is a wet closed drainage system, what we call a wet system. Okay, I told you not to worry about wet between wet and dry. I'm going to show you the difference in just 1 minute. Okay, so this is based on those 3 principles I talked about in another video, right? The 3 bottle system. So this first chamber right here, okay, this is the collection chamber. As you can see, this tube right here drains right into that, okay? This gets hooked up to your patient. Okay, it's calibrated, okay? So you can see little markings here. These are numbers. That's so you can do your I and O, okay? So this goes up to 2,500 mLs. Once it fills, you need to change the whole system. We never empty anything out of this system. It's a closed drainage system. That's to prevent infection, obviously. Now, if you do have to get a sample, there is a sample point back here. If your physician wants to run a culture or something on your drainage, you can get one back there, okay? So that's an option. This is the water seal chamber. This is where you're gonna look for an air leak. This, you're going to fill up to 2 centimeters of water right there. Once you do that, when the patient breathes, there's going to be titling. It's going to go up when they breathe in and down when they breathe out, okay? This is the chamber that you are going to see an air leak. So look for a small intermittent bubble when your patient exhales or maybe when they cough. You should not see constant bubbling in the water seal chamber. If your patient didn't have a pneumothorax, then you wouldn't expect an air leak, okay? So if they develop an air leak, then that's a problem. You're going to have to assess your patient, call a rapid if you need to, and let the physician know. Okay, now this third chamber, remember this is the suction control chamber, sometimes referred to as the water suction control chamber. This is a wet system. So this would be filled up to 20 centimeters of water. Right here is that line, okay? And then this goes to that chamber, this tube. You would hook this up to low wall suction so that this has gentle bubbling in it, okay? And that's how you would, that's like basically the principles of this. Now, on the back of this, it comes with a little cylinder here that you can put on top and fill your chambers with sterile water, okay? Usually the person who sets up the chest tube does that before the chest tube is inserted. So that may be something you may do as a nurse, okay? Now, in contrast to that, I've got a dry system right here. Now this system, the difference with this is that there is no water in the suction control chamber. So it still has the same collection chamber. It still has the same water seal, okay? The only thing is that the suction control is dry, okay? So there's a little toggle over on the side that I can set it, and this one is set for -20. Now, the one difference is that with this wet one I just showed you, the Pleurovac, that can only go to -20. Okay, this can go up to -40. So if a physician wants more negative pressure exerted, they could use this dry closed drainage system, or maybe it's the only closed drainage system they have in the organization, and they would use that as well. So that's about it for chest tubes. Whether they're wet or whether they're dry, the nursing care is always going to be the same. So some of the things that you need to watch out for if your patient has a chest tube is number one, if their O2 sat goes low, you might call a rapid, right? If it's under 90, you might call a rapid. If they have a pleural chest tube and it drains more than 70 milliliters an hour, okay, that's an important number, okay? You're going to call the physician. That's a reason to call the physician. If they have a mediastinal tube and it drains more than 150 milliliters an hour, you're going to call the physician, okay? Those are some points. The only thing is immediately post-op with the pleural chest tube or with mediastinal, it might be a little bit more than that in the immediate post-op, but certainly by the time they get to the either ICU or the floor, if this is post-surgical, that you're going to call if it's greater than 70 with a pleural or greater than 150 milliliters if it's a mediastinal tube. Okay, that about does it for chest tubes.